Hello, my name is John Evans, and firstly, I would like to thank Ben Hampstead for the kind invitation to contribute to today's symposium. I'm so sorry that I can't be with you. Unfortunately, it clashes with a teaching block for us, but hopefully there's some interesting ideas in here for you. The first things I want to do is say a few preliminary comments just to set the scene for my presentation. And the first thing is that I guess to emphasize that my own work has primarily been with younger adults with acquired brain injury. And although I've certainly done some work with older adults and increasingly with people with dementia, I want to emphasize that the context of quite a bit of what I'm going to say today in relation to interventions for executive dysfunction comes from work undertaken with younger adults with acquired brain injury. However, hopefully that stimulates some discussion about the relevance of this and these ideas to older adults and to adults with dementia. A second point that I'm going to make is that during the talk I want to emphasize the potential value of focusing on specific aspects of executive functions and different types of executive functions, and having interventions aimed at those domains or the specific functions. But I always want to emphasize that this should be set in the context of supporting everyday functions for which executive functions are required. And I think the best way to ensure that is to start with identifying a person's goals, their personally relevant goals at the activity and participation levels. And I know that Linda Clare's work, which you're going to hear about more later on, has very much taken that approach. But I do think that we can target specific executive functions, or we should be thinking about whether we can do that. But to support that, we need good models, and in clinical practice, certainly we need good neuropsychological formulation. So I'm going to talk a little bit about models shortly. And towards the end, I'm going to take a bit of a specific focus on prospective memory, as that's been a particular interest of mine. So theorizing about executive functions, I think obviously people will be aware that that has come from several different directions. So one of which is an anatomical focus of thinking about what are the functions of the frontal lobes, how do we understand the deficits caused by damage to the frontal lobes. But that work has also been influenced by questions of a more cognitive nature, such as how do humans solve problems and manage complex everyday activities. And this has led really to, or these two approaches, I suppose, has led to some models of executive functions which are primarily driven by understanding the cognitive processes involved. And then other models which I guess start from the question about what do different parts of the frontal lobes do and contribute to executive functioning. The topic of models, cognitive models of executive functions, of course, is huge. So I'm going to restrict myself to a model or framework which I've found useful over the years in clinical practice and in research studies, and continue to do so. And I'm also going to emphasize that I think that this particular model actually is quite complementary with some other models which are more anatomically focused. So this work, of course, is the work of Challis and Burgess and colleagues, and their explanation of the supervisory attentional system. And this, of course, was introduced to try and conceptualize the sort of processes that are involved in addressing problem solving, dealing with novel situations, and so on. And this model, I'm not going to go into great details, and many of you may be familiar with it, but in a sense, the model highlights a number of different processes involved in problem solving, in planning, implementation of plans, and monitoring of task performance. So within this framework, the central area here is really focused on, in a way, problem solving and generating a potential solution to a problem. The second domain down here is related to the implementation or the initiation of action, the implementation of the plan. And then the third area over here refers to the assessment or verification, or in a sense, the monitoring of behavior, the monitoring of action, in order to determine whether an implemented plan is achieving the intended goal. So a complex set of processes, but what's nice in a sense is it adds a little bit more definition and specificity to the broader construct of executive functioning. Turning to an anatomical model, again, the model I quite like is the one, it reflects the work of Don Stuss and his colleagues. And what this model does, of course, is take different regions of the frontal lobes and highlight the potential for those to have differing contributions to executive functions. So, for example, the dorsolateral frontal lobes are divided into left and right, with left being particularly involved in what Stuss called task setting, which one might think of as planning or forming intentions. The right dorsolateral prefrontal cortex more associated with monitoring of task performance. The superior medial circuit being important for the initiation of actions, for the implementation, or as Don Stuss put it, energization. The lateral or medial orbitofrontal circuit being important for regulating actions with reference to anticipated emotional outcome, behavioral self-regulation. And then the rostral prefrontal cortex, or Brodmann area 10, this is an interesting area which Stuss referred to as a sort of metacognitive area. I draw heavily on the work of Paul Burgess and his colleagues, who emphasized the role of area 10 in the regulation of attention between the external world and the internal mental world. So, as I said, I think these models are actually rather complementary. And in many ways, we might see this sort of central area of the Stuss and the Shallis and Burgess model as being sort of reflecting particularly the task setting highlighted by Stuss. This area down here in terms of the implementation of schema perhaps reflects the initiation and the energization component. And finally, the assessment, verification and monitoring of behavior again seems to reflect both perhaps the combined performance of this right dorsolateral area and also rostral prefrontal cortex area 10. So I think we've got some useful models, I think, which make sense in a clinical context in understanding the range of functions that we might characterize as executive functions. So what about rehabilitation then? Well, actually, certainly in the area of acquired brain injury, we've reached the stage, I think, where systematic reviews are being produced and clinical people feel confident enough to write clinical guidelines. And in fact, rather hot off the press, there's a set of guidelines called the INCOG guidelines, previously produced in 2014, and have just been updated literally in the last couple of days. These new guidelines have appeared. And there's a set of, INCOG have a set of guidelines for different cognitive domains, and one of which is for executive functions. So if we turn to the recommendations that arise from these, and in fact from other systematic reviews and clinical guidelines, they are fairly consistent. One of the central recommendations really refers to the use of metacognitive strategy training, or metacognitive strategy self-instructional interventions. So this would include things like goal management training, the plan, do, check review, and sort of training in the process of problem solving, planning, and so on. The recommendation is that these sort of strategies should be used for individuals with TBI, for difficulties with a range of executive functioning impairments, include problem solving, planning and organization, and other aspects of executive functioning. They suggest that the common elements of many of these different types of strategies are self-monitoring, incorporating feedback into future performance, and emotional self-regulation. I'll come back to that. But as I said at the beginning, one of the things that's nice to see in these guidelines is they always emphasize the importance of focusing these strategies on everyday problems and functional outcomes of personal relevance. One of the things the INCOG guidelines do is provide a sort of an algorithm, and this may be, depending on the screen you're seeing this on, maybe a little tricky to see the detail. But essentially, it's a fairly sort of simple algorithm, which really highlights the importance of following an assessment, considering issues to do with awareness and motivation, which may need to be addressed, for example, prior to the use of other sorts of more complex strategies, such as the metacognitive strategies. I've used a version of this type of thing for several years now, and reflected in this, again, probably tricky to read diagram here. And what I suppose I tried to do is both reflect the issues of the importance of considering awareness and insight, but also reflecting that when we're selecting interventions, a critical issue is to consider whether the severity of impairment, both the severity of executive impairment and actually the severity of other cognitive impairments. Let me just work my way through a little bit this. I highlighted earlier the critical process and critical importance of a good neuropsychological assessment and formulation. That's, of course, the starting point. I also highlighted the importance of even when we're considering specific interventions for executive deficits, setting that in the context of a person's core rehabilitation goals. One thing that's always necessary to think about is the extent to which a variety of other factors will be impacting on the sorts of tasks and everyday activities that may demand executive functions, but can be influenced by a variety of different difficulties. For some people, we may rarely perhaps dealing with a rather specific executive function, but then we still have to think about the issue of awareness. However, for many people, a range of other factors, psychological factors, sort of mood, worry, anxiety, as well as things like sleep, fatigue, pain, medication, that may be impacting on executive performance. Returning to the issue of awareness, of course, for somebody who has difficulty with awareness and insight, it's going to be hard to use things like goal management training and all these more complex interventions. So we may need to support that person to develop some awareness through education, feedback, training in self-monitoring, and so on. For some people, it's just not possible. They're going to struggle to have sufficient awareness and insight in order to be able to implement more complicated strategies. And so there we may think about strategies to support modifying the environment, things like consistent routines, prompting, external prompting, and checklists, and so on. But for some people, we may be able to think about particular interventions. But again, we need to think about how severe is the executive dysfunction. For those with more mild to moderate executive dysfunction, then I think we have got a number of different options available to us. Again, in these more sort of self-instructional goal management training, problem-solving training, autobiographical memory cueing, and so on. Whereas for others, again, with more severe impairments, those complex interventions are not going to be feasible. But we can return to issues and using techniques such as managing the environment, providing routines, checklists, external prompting, and so on. So I highlight this, I suppose, just to reflect that rehabilitation for executive functions, like all cognitive rehabilitation, is not one thing for everybody. We have to carefully select interventions, but we have a number of options available to us. When we think about the metacognitive strategy training programs, well, over the years, we've seen a variety of sort of forms of these, but they're all broadly similar. Back in the early days of our work at the Oliver Zangwill Centre in the sort of late 90s or mid-late 90s, we used to develop a group-based format focused on attention and executive functioning sort of training, as I said, done in a group. And in fact, Eliana Miotto, who you heard from earlier, evaluated this particular group format in this study here and found it was beneficial. And similar programs from Joke Spikman in the Netherlands, multifaceted treatment program focused on a combination of problem-solving training and goal management training. And another example, work of Sveinung Tornas and colleagues in Norway, in Oslo. And Sveinung and colleagues used, again, a combination of goal management training, the full goal management training program, plus the use of alerting, and I'll come back to that a little bit later, and some mindfulness as sort of emotional regulation. So a combined package. And these elements were sort of common themes in these programs. I've mentioned goal management training a few times, and I'm sure many of you will be familiar with this. It's originally developed by Ian Robertson and built upon by Brian Levine, Tom Manley. And again, a simple concept, really, one of sort of training a self-instructional strategy based around getting people to regularly stop and think, to pause, to take a mental moment, in a sense, to keep things, intended tasks or the steps in a complex task on a mental blackboard. For me, the core element here is this sort of stop, think, and the mental checking routine, which is trained to become a habit, supporting that maintenance of intentions. In many ways, you could say it's a bit like sort of exercise for Bodmin Area 10, that sort of moving attention from the external world to the internal mental blackboard, or the mental to-do list, if you like. So much of the work that I've talked about, many of the studies, of course, have tended to be with younger adults with these multi-component interventions for executive dysfunction. But a nice example recently from Cisneros and colleagues, who have taken this program, and they've very much used Jokas Bickman's work, and with the cognitive enrichment program, but within a group of older adults with traumatic brain injury, in a trial that compared a treatment as usual group with a group that had treatment as usual plus this cognitive enrichment program, which included training in planning and problem solving, and the goal management training, with strategies focusing on self-awareness. And this was a small study, like so many of our studies, was relatively small. The effects were modest, but promising, a common outcome, I suppose. And they concluded that the study did show that older adults with TBI could improve their executive functioning, with a positive impact on everyday activities. And what I liked about this study was the use of what they referred to as a resumption of daily activities, so that had been abandoned after the TBI. So it was in a sense, a checklist of things that people had previously done before their head injury, that had sort of been abandoned, and looking at how many of those were able to be resumed in the course of training. And there was a benefit for those who had the executive functioning training. So some positive evidence that this might translate at least into older adults with traumatic brain injury. So in a way, I've been talking about interventions, these sort of multi-component interventions that you might say are really trying to target many of these different aspects of the executive function system, if you like, or the planning, the problem solving, and the task management system, all in a combined way. We tend to sort of, I guess, throw it all in a package in order to try and ensure that all the best outcomes. But over the years, I suppose we've also had a look at trying to highlight interventions for specific areas, which we've then incorporated into the multi-component packages. So, for example, this element of drawing upon past episodic memory or autobiographical experiences in order to help generate solutions for novel problems. So in this study, we investigated a sort of a brief training procedure where we were, in essence, cueing or training people to stop and think, and to draw upon previous experiences to support them in problem solving, and found that was beneficial. Similarly, in this particular single case experimental design study, here we had a patient who had a ruptured aneurysm and had severe deficits in both the particularly the initiation of behavior, initiation of action, but also in the sort of self-monitoring. So this particular lady found it very difficult to initiate activity, but also if she was able to initiate, she was also highly distractible. So would fail to complete tasks because she would be distracted. Here we used an external queuing system, basically a paging system, to prompt her to deliver a fairly loud sort of alert and a vibration, which actually enabled her to initiate her actions, but also critically to maintain her attention to her intended action. And this links into this work we've also done on the potential for adding in queuing into some of these other, particularly into goal management training. So if we think about task completion, in the sense of the requirement to hold things in mind and to carry them out over time, there's this requirement to sort of maintain an intention to do something. And what we've explored in various studies is the idea of delivering a cue, which basically prompts people to do that stop, think, and to reflect on things that are intended, things that are sort of still on that mental to-do list. And this featured in this well, in all of these studies, but particularly this combined with the full goal management training in the Tornas et al. Study. So hopefully what I'm highlighting is that I think we can, in a sense, conceptualize it. If we conceptualize the different elements and different components of executive functioning, theoretically, of course, we may be working with people who have deficits in one or other, but theoretically limited. And if we're going to get sophisticated about it, we could potentially be designing interventions which would target those specific areas. Or at least by understanding interventions for different areas, we can then add them into multi-component intervention programs. I just want to, sort of the last section really, just to sort of focus particularly on the topic of prospective memory. In a sense, it's a perfect illustration of a task that requires the integration of memory, attention, and executive functions. So, of course, the classic prospective memory task is the remembering to mail a letter. So, if I have a birthday card I want to mail tomorrow, I have to write the card and then realize that on my way to work tomorrow, I'm going to pass a mailbox, and the opportunity to mail the letter will arise, and I can hopefully execute my intended action. So prospective memory, as I say, is a sort of perfect example of a behavioral task requiring a set of cognitive processes that include the planning, when am I going to mail the letter, the memory, my memory for the intention, monitoring and cue detection, and then initiation of action. So prospective memory critical for everyday life, and you know, a real exemplar of what we think of as a sort of executive set of executive functions. So in terms of strategies for managing prospective memory, nice paper from last year by Jones and colleagues, a systematic review and meta-analysis of mnemonic strategies, cognitive training, external memory aids, and interventions that combined these sorts of interventions. So they looked at things like efficacy, the nature of the measurement of outcome, and then some characteristics of the studies. And so one of the interesting things from this review was the finding that if you look at effect sizes, then in fact, external memory aids do pretty well. And also quite a lot of the studies of external memory aids also have a pretty good sort of ecologically relevance to them. On the downside, many of the studies of external memory aids are fairly small in sample, and few of them are randomized controlled trials. But And I'm going to come on to, I think the use of technology and external memory aids is something that's so far still underused, but and we need to get better at it. So, but we're seeing evidence that strategies that are useful with older adults for supporting prospective memory. And one of the things that we are interested in is to what extent are these strategies being used or recommended for people with dementia or MCI. So my trainee, Katie Ferry, did a survey study here in Scotland, the Scottish Memory Aid Survey. And we looked at what memory aids were being recommended for people with dementia or MCI by healthcare professionals, including nurses, OTs, psychologists, and so on. Again, lengthy study, I don't have time to talk in detail, but what you see here, and again, you don't necessarily need to read the detail, I just wanted to sort of illustrate the overall findings. But so here what you see is these are a set of items where we're asking to what extent did the professionals, and there were 142 people responded, to what extent did they often recommend these interventions or strategies. So you see, for example, the blue ones here are what we call the non-tech or the low-tech strategies. So this is wall calendars, wall charts, sort of diaries. So those are often recommended by more than 80% of the respondents. Similarly, the sort of general memory strategies, such as leaving objects in the same place so you know where to find them, or leaving objects so they'll be able to remind you to do things. Again, high levels there. The red ones are the use of tech, in a sense, some sort of tech. And again, if we just focus, for example, here on mobile phones, well, only 20% of people said that they often recommended the use of mobile phones. We explored in this study the sort of nature of the potential barriers to use of things like technology. And whilst almost all the professionals felt that technology could be useful, many of them also felt that there were barriers such as that people would find them difficult to use. And that may influence why they don't recommend them that often. So that highlights potential need to actually get better at providing technology which is simple enough to use, but actually provides the benefit of active prompting. One example of that is this one. This is MindMate, which was developed here in Glasgow, and my trainee Claire McGoldrick evaluated this in a single case experimental design with 3 people with dementia. MindMate's an app which runs on a phone or a tablet, has a variety of different components to it, but one of which is a simple reminding system. As I say, we did this in a SCED, in a multiple baseline design, with a SCED, 3 participants. And I guess if you just concentrate here, this is the nicest example. The person at the top here shows a really clear benefit from baseline levels when they're not using the app to when they're using the app. And this is successful completion of everyday valued activities. This person actually didn't get on with the app and basically didn't use it after the first week, but she and her husband were able to continue collecting the data. So in a sense, this is an extended baseline. The third person, again, also showed a significant benefit, although they actually had been doing rather well during the baseline period. So overall, it doesn't work for everybody, but for some people, and particularly here we might see this person, the use of a simple to use reminding system considerably improved their ability to independently carry out intended activities. We've also developed an app of our own, which is called Apple Tree, again with the idea of having a simple interface that supports people to put in reminders and then also actively prompts them to use it, as well as prompting them for the particular reminders. We've done a variety of studies with this now, showing that it leads to more accurate entry of reminders than things like Google Calendar, and the prompting, when we provide active prompting, then people use it more. And we've completed a feasibility randomized control trial of this. We've also just recently finished a study using it in a single case experimental design study with people with Parkinson's disease. again, some mixed results, a bit like the other MindMate study, with some people benefiting and others not so much. Okay, so I'm going to finish there. Well, as I said, a lot of the work that I've talked about, I guess, has come not necessarily specifically with older adults or older adults with dementia. But what I'm hoping is that in a sense, we have that opportunity to discuss or think about a sort of a theory-driven, a model-driven approach to the rehabilitation of executive dysfunction, but nevertheless one that's set very clearly in the context of supporting people to undertake and carry out everyday activities that are important to them. Thanks for listening and enjoy the rest of the meeting.